Good evening, and welcome to the Cure HHT webinar series. I am Nicole Schaefer, Director of Professional and Medical Programs for Cure HHT. Thank you for joining tonight's webinar, IVF and Pre-implantation Genetic Testing for HHT. Just a few reminders for tonight's webinar. It is being recorded and will be posted on our website. After the webinar, you will receive an email with a short survey. Your input is critical to the development of future webinars, so we appreciate you taking a few minutes to complete this. To help reduce background noise, everyone's phone or microphones have been muted. To ask questions throughout the webinar, go into the gray panel on your screen and type your question. I will ask as many questions as time allows during the second half of the call. And please remember to ask general questions related to today's topic so the answers will benefit everyone on the call. Before we begin, I would like to introduce tonight's speakers. Katie Wusik Healy has worked as a genetic counselor at Cincinnati Children's Hospital Medical Center for 11 years. She specializes in genetics of vascular malformations and sees patients in many specialty clinics, including the Cincinnati HHT Center, the Hemangioma and Vascular Malformation Center, the Cerebrovascular Clinic, and the Familial Cerebral Cavernous Malformation Clinic. Katie has a particular interest in the diagnosis and management of pediatric patients with HHT and participates in research in this area. We're also honored to have Despina Curtis. She's an HHT patient and former Cure HHT board member. Despina and her husband have gone through the pre-implantation genetic testing process and will share some of their story and insight with you. She and her husband Simon have two beautiful children, Bella and Banks. So I now turn over tonight's program to Katie.
Hi, thanks, Nicole. So just kind of a brief overview of what I'm going to talk about before I turn it over to Despina. I'm just going to briefly review some key points about inheritance and genes that we'll need to know while we're talking about genetic testing options. I'm going to focus on genetic testing options before pregnancy, but also just mention a few that you can pursue during pregnancy or after pregnancy, and just some considerations for each option that you should think about as you're thinking about whether or not these are options you'd like to pursue for your family. And I just want to give the disclaimer that there's no right or wrong option to choose when you're thinking about these things, but just some different things like cost or things like that I want to make sure everyone's aware of so you can make the best choice for your family. So just quickly, hopefully we all know that HHT is autosomal dominant, and if you're a person who has HHT, you have a 50-50 chance with each pregnancy of passing the condition on. The three main genes that cause HHT are ANG, ACVRL1, and SMAD4, but there are a couple of other genes that I've listed up here that can also have some overlap with HHT symptoms. And ANG and ACVRL1, of course, are the most common causes of HHT, with SMAD4 and GDF2 being much more rare causes, but about 10 to 15% of people won't be able to identify the underlying genetic cause of their HHT. And that becomes important when we're thinking about genetic testing and using that in family planning purposes. Just quickly about genetic testing, some basics. If you've been through genetic testing, you probably already know this, but there are three different potential outcomes of genetic testing. The genetic testing for HHT could be negative, and of course that does not rule out a diagnosis of HHT for you. It just means, again, that you fall into that 10 to 15% of families where we can't identify the underlying genetic cause. Your results could be positive, and for most people with HHT, this is the case. Positive results confirms the diagnosis of HHT for you, and it allows other family members to be tested, including pregnancies. Or it could be uncertain, and that's where we've identified a genetic change, but the lab isn't certain whether or not that genetic change causes HHT or is just general variation in your DNA that doesn't cause HHT. And so an uncertain result doesn't rule out or confirm a diagnosis for HHT for that person. And the reason I'm talking about that is because if you want to use genetic testing for family planning, meaning pre-implantation genetic testing or prenatal testing, you must have had a positive result from your genetic testing in order to pursue that. So just quickly, if you're someone who has not had positive genetic testing yet, it doesn't mean you have to give up and you might not be able to pursue these options, but before you can, you might want to consider seeing a genetics professional if you haven't already. And I'd say preferably somebody who's at an HHT center of excellence, because they can help you to confirm the diagnosis. Do you really have HHT, or do you have one of those HHT like conditions with some of those other genes that might be causing your symptoms? They'll be able to talk with you about different reasons why your genetic testing might have been negative. So there are things like mosaicism that you might have heard of, where not all of the cells in your body have the genetic change for HHT, so it might not be picked up on kind of routine genetic testing. There are different newly identified types of genetic changes that can't be tested for right now in kind of clinical testing. And so there might be some other options that you need to think about, like research options or testing for those additional genes that can cause the HHT-like symptoms. So just some things to think about if you're someone who's not had genetic testing yet, or if you have and it wasn't positive. Okay, so moving on to kind of the reason that we're here to talk tonight is thinking about genetic testing for family planning. And like I mentioned, I'll focus on the PGT or pre-implantation genetic testing. PGT is also in the past and still currently sometimes called pre-implantation genetic diagnosis, but you'll hear me talk about it as PGT throughout the presentation. And then I'll just talk briefly about during pregnancy and immediately after birth options for testing children or pregnancies. So pre-implantation genetic testing is always used in combination with in vitro fertilization or IVF. And I just am going to walk through kind of each of the steps that someone would go through for PGT and talk about kind of considerations during each step of things to think about as you're making the decision about whether or not this is an option for you. So the first step is that a couple meets with a fertility specialist. They undergo IVF. Their embryos undergo genetic testing, and then selected embryos are transferred to the woman's uterus. The woman hopefully becomes pregnant, and the result would be the birth of a child without HHT. So I'm going to, like I said, just go through each step and give some more details and considerations to think about. So when you're meeting with a fertility specialist, you want to make sure that you're meeting with someone who's comfortable facilitating PGT for you, because it's really the fertility specialist that is going to be harvesting the embryos and sending the embryos to a lab to do the PGT. So the people, if you go to an HHT center of excellence, they're not going to be the people who are kind of facilitating this testing for you. They can help you and provide, your genetic test results and things like that, but it's really going to be the fertility specialist and the specialized PGT lab that will be doing the testing. So when you're meeting with a fertility specialist, just make sure that there's someone that feels comfortable with that process. They can go over with you kind of the details of the IVF process. I'll talk about it just briefly here. They'd talk with you, about any risks of the medical complications that you're going through. They'd talk about a treatment timeline and cost and kind of go through all of the details of what that would look like for you specifically. For IVF, I just wanted to briefly talk a little bit about the process itself. So typically the woman takes daily injections of hormones to help stimulate egg production. And once egg production's been stimulated, then eggs are retrieved from the ovaries. They're fertilized in the lab with a sperm sample from the father. And then hopefully some of those eggs are fertilized and become embryos. And then typically the embryos are cultured for 3 to 5 days. And then some of those embryos would be implanted in the woman. Each fertility center is going to have a specific policy for how many embryos they would transfer at one time. So it's another question to consider when you're talking with someone. So some things to consider regarding IVF itself is just what the insurance coverage might be. So in the United States, it's less likely to have insurance coverage than it is if you're in Europe. Some, though, insurance companies do cover maybe parts of IVF, and they might have like a dollar amount or a max amount that they would pay towards insurance coverage. So just something to look into if you're considering this. I would say in the US, the information I was looking up for this webinar is that the average cost per cycle is $12,000 in the US, but I think that can vary widely based on the fertility center that you're using. You might need to undergo more than one cycle. We're going to talk about what a cycle is and when we might need to loop back and think about repeating a cycle. So the cost might be higher than just one cycle. It certainly can be stressful on both partners. It may put additional stress on the woman's body as she's the one who's undergoing kind of the additional hormones and the injections daily. And then you might want to ask the fertility center if this is a concern for you about what the policies are for any remaining unimplanted embryos. Often embryos are frozen, but if you're planning not to use those embryos at any point in the future, you might want to know what they plan to do with them. The next step is really the pre-implantation genetic testing step, where the embryo would undergo genetic testing to find out does the embryo have HHT or not. And that's done with something called an embryo biopsy. So they're going to take part of the embryo. There are several different methods. I'm not going to go into exactly how they do it, but they take part of the embryo and they're basically testing the embryo to see, does the embryo have that same genetic change that was already found in the parent who has HHT? There are some methods that are becoming less common that would only work if the woman had HHT. So you just want to check again with the fertility center and the PGT lab, and figure out if the PGT lab can detect the genetic change that is in your family. And typically, like I said, it's going to be sent to a highly specialized lab. There's probably a handful in the country, and your fertility specialist is going to contract with them. The genetic testing is not usually performed by the lab that did kind of your initial genetic testing for HHT. And typically you're going to have a consultation with the PGT lab where you might speak with the genetic counselor. Many of them have genetic counselors working with them and kind of walk through some of the different considerations that I'll mention. So some things to consider about PGT is that there is an additional cost to IVF of the PGT. Again, the cost can range widely, but most estimates I looked at were about $6,000. It doesn't actually work for all genetic changes. And so it could be that when you have a consultation with the PGT lab, that they talk to you about what's the likelihood that they'd be able to identify your specific genetic change. It could be that when you go to test the embryos, all of the embryos have HHT. The chance of all the embryos having HHT versus only half or none of them having it is the same. So you just might want to consider if that happened, kind of how you would proceed from there. Again, I mentioned, kind of what are the plans for any embryos that aren't transferred to the woman, but also what are the plans for the embryos which do have HHT. So some people are uncomfortable with the idea of discarding these embryos and kind of what it says about the quality of lives of those people who do have HHT. But, other people are uncomfortable with the idea of having a child with HHT. So that's just something to think about as you move forward. It's possible that undergoing PGT itself might decrease the likelihood of pregnancy. And I'll talk a little bit in a few slides, just kind of what is the general chance for a woman to become pregnant with IVF. And there's also a small chance that the testing is not accurate. So very rarely, sometimes the PGT may not work the way that we want it to. And that's kind of a risk with any highly specialized genetic testing that we're doing on a very small amount of DNA. So usually when we're testing people's blood, we have lots of DNA that we can test. But when we're using an embryo to test, we really have only 1 or 2 cells. And so the amount of genetic information that we're testing is just much smaller. If you're undergoing PGT for HHT, you also have the opportunity to do some additional genetic screening at this time, typically for chromosome conditions. So for things like Down syndrome and other more severe chromosome conditions. It's not exactly diagnostic testing. I'm not going to go into the details of that, but just know if you're undergoing PGT for HHT, there might be some additional screening you could do if you're interested as well. It would be at an additional cost, but something to talk about with the fertility specialist in the PGT lab. And then the next step is for selected embryos to be transferred to the woman. Just one consideration I want to point out is that there's a small chance that the wrong embryo or embryos could be transferred. And so that could mean that an embryo that does have HHT is transferred instead of an embryo that doesn't have HHT. And then the next step hopefully would be that the woman becomes pregnant. So the chance of pregnancy for women with IVF in general decreases as the woman ages. And there is, of course, an increased chance for a multiple pregnancy if more than one embryo is transferred. And again, checking with the fertility specialists about how many they typically transfer and kind of what their policies around that are, depending on how concerned you are about that. And in general, when we're using IVF and PGT, they're always recommending confirmatory testing during pregnancy. And I'll talk about kind of what those confirmatory tests would be when I get to the during pregnancy testing portion. If the woman doesn't become pregnant at this stage, if there are additional embryos that have been frozen available, you could go back, kind of the next step would be transferring additional embryos. And if there aren't any more embryos available, then the option would be kind of to go back and do another round of IVF, starting with, you know, the retrieval of additional eggs and then going through the rest of the steps again. And at the end, of course, the hope is that you'd have the birth of a child without HHT. Just some other things to think about if you're not wanting to use PGT. You could consider using an egg or sperm donor, depending on which partner has HHT. And for those people who are uncomfortable with the idea of what would happen to the embryos that have HHT, in this situation, you know, you wouldn't create any type of embryo that wouldn't be implanted. And so that's just something else to think about. If you're using a sperm donor, you don't even necessarily have to go through the IVF process. They can use something called intrauterine sperm injection, where the sperm are introduced to the uterus during kind of the woman's normal cycle. Okay, and then I'm just going to mention prenatal testing. So this is obviously testing during pregnancy. And the confirmatory testing that would be recommended if you've used PGT during the pregnancy, or if you wanted to do prenatal testing, is chorionic villus sampling, or CVS, or amniocentesis. And those are done at different points in pregnancy. So if you do it earlier, you'd use a CVS. If you're doing it later, you'd do an amniocentesis. And this is where they're sampling cells in CVS, cells from the placenta to do genetic testing. And in the amniocentesis, they're using the baby's skin cells that they get from the amniotic fluid that's surrounding the baby. And of course, with these, you find out during pregnancy if the baby has HHT. And so it wouldn't be something that you would know beforehand. For prenatal testing, results usually take at least a couple weeks, up to a month. It tends to be less costly than IVF and PGT. But of course, you're already pregnant when you find out if the baby has HHT. And so if you're really wanting to not have a baby with HHT, then you need to consider, you know, would you feel comfortable with terminating the pregnancy at that point? There are some risks associated with the CVS and the amnio, with the biggest risk being pregnancy loss. Each center that does these typically has their own risk for pregnancy loss that they'd be able to tell you, but it's typically less than 0.5%, ranging anywhere from 1 in 200 to 1 in 1,600. There is also kind of a new technique that uses fetal DNA, or the baby's DNA, that's floating around, not inside a cell, in the mom's blood. And so you might hear it called non-invasive prenatal sequencing. And so basically you're able to test the mom's blood, and you're actually looking at the baby's DNA. And they're just starting to use this technique for conditions like HHT. So I don't know that it's been done for HHT yet. There's not a lot of data about how accurate this type of screening is. It's not considered diagnostic at this point, meaning it wouldn't say for sure, yes, the baby has HHT, or for sure, no, the baby doesn't. And some labs might only be able to do this testing right now if the HHT is inherited from dad. And just like with PGT, they recommend doing prenatal or postnatal confirmatory testing, so the amnio or CVS, or testing the baby after birth. And I think this is really an up-and-coming technique, and so something that maybe isn't ready for routine use right now, but might be ready in a couple of months, a year, just kind of depending on how frequently they start doing this and how much information they can give about how accurate it is. And then just quickly, postnatal or after birth testing, you can do cord blood testing. This is when we do testing immediately after birth, using blood from the umbilical cord. So it's the baby's blood that's in there. And it's typically collected by the OB or the delivering doctor in the delivery room. And some considerations with this type of testing is that it avoids an extra blood draw for the baby. But I'll say from experience, it can be really difficult to coordinate if the delivery hospital doesn't have any genetics professionals there, just because they're not used to ordering and sending out genetic testing. You typically find out within the first few weeks if the baby has HHT with this process, but of course it doesn't prevent the baby from having HHT. And the cost of the testing would be similar to if you're testing any family member for HHT. One of the differences though here is if you're doing cord blood testing, you typically also have to submit a sample from mom. And the reason for that is just to make sure that they're not accidentally testing mom's blood instead of the baby's. And of course you can do genetic testing anytime after delivery or during childhood. You can do testing on a blood sample and oftentimes a saliva sample. At our center, we typically recommend testing within at least the first 3 to 5 months of life, as we know the baby has a 50% chance of having HHT. Because if the baby's positive, we'd recommend a brain MRI within the first 6 months, and then we'd also talk about screening for lung AVMs too. And so we want to make sure we get that genetic test result back, and there'd be time to schedule that imaging if needed. And I just quickly want to acknowledge our HHT center in Cincinnati. And then turn things over to Despina to talk more about her experience.
Okay, Katie, that was a really amazing job. Thank you, everybody, for having me here tonight. Anything that I don't talk enough about or don't flesh out quite right or give enough good detail on, feel free to ask me during the Q&A or email me or contact the foundation and they can get in touch with me. Because I tried to go over this with my 3-year-old earlier and she told me, no, mommy, your friends are not going to like all that talking. So I hope we prove her wrong, and I am very, very excited for some conversations with adults here tonight. But just sort of an introduction to me. I am 35, halfway to 70, almost 9 years married with a rock star of a husband who is incredibly supportive. My sassy 3-year-old, who I talked about just a bit ago, and she has a 1-year-old sidekick. That's Bella and Banks. And he's just as wild. He's just not as verbal as she is yet. And these 3 really are the loves of my life. And it's been 6 years since my mom passed away from HHT, and 5 years since I found out that I myself had HHT. So rewind back to when I first knew that PGD or PGT, I'm probably going to refer to it as PGD, but it was 15 years ago when I was undergrad in college, and I was a genetics TA, and this was very new and up and coming, and it was often like the very last thing we had in our course pack. And I remember thinking, oh my gosh, this is crazy, but it didn't really apply to me until it did. And I was married in 2011, and a few months after, we decided to just go ahead and test. And the moment that really stuck with me is I wasn't really worried about the appointment and hearing whether or not I had it. It was going to be hearing I had it and then having to relay that to my mom. because what I did, I could, like, she crashed to the ground, and it was through a phone conversation, and so I couldn't see her or even hear it, but I could literally feel it through her voice. And it was this like primal response, and I couldn't wish that upon anybody. And it didn't matter how asymptomatic I told her I was or how fine I was going to be. It just crushed her. So knowing what I did and that it was an option, I had talked about it with the genetic counselor at that appointment, and I promised her that her grandkids wouldn't have it. So my mom unfortunately went on to get sicker and sicker. And in 2012, she listed for a double heart and liver transplant because she has the ALK1 gene, or she had the ALK1 gene mutation that caused liver AVMs and the heart failure. And she also, 5 years before that, had a sister that had the biliary involvement, and she had passed away. And then somehow at the same time, she had yet another sister, so there's 3 of them, who had liver involvement as well, but she had the 3rd type, which was the pulmonary hypertension. And my aunt got a liver transplant and bled and died. And my mom died waiting 3 days after her. But I reminded her of what I had said, and I honestly believe that that gave her peace, that it was going to end at me. The HHT was going to end at me. So it was a long, hard year of grieving, and we hit the ground running. Basically, in the beginning, it's a bunch of consults. I had baseline scans to make sure, doctors knew where my liver stood before undergoing all the hormones and things like that. And you get a spinal MRI just to make sure that you would be okay for an epidural. Then there's anatomy checks pre-pregnancy and consent forms that we signed. And then there was a big piece of it is the third-party labs, which Katie talked about. But here when you go in, you basically just get swabs of you and your partner, and they send it off to the lab. And they come back usually in a couple of weeks and say, okay, we've got what we need, so you can go ahead and proceed. And then there's med classes, so they, thoroughly go over a calendar and meds and sort of alleviate some of the overwhelming steps. And there's a baseline ultrasound and some blood work, and then it usually takes about 10 days of the medication, and then there's a retrieval, which basically they get your ovary ready with as many follicles as possible, so that they're sticky enough that they stay in the follicle, but they're mature enough that when they take them, they have really good odds of becoming fertilized. And from there, it's really a numbers game. So at last check, they required something called ICSI, which is where the embryologist will take a single sperm and put it in the egg. And then the next day they check and see how many fertilized. Day 3 is when I believe they laser a little tiny hole, at least this is how they did it. And as this embryo is growing, it divides. There's cellular division, and it pushes out this genetic material that they take, and then they can test. So they freeze them at day 5, and they test everyone that made it to day 5. And they send these samples off. And then you sort of wait for the results, which in our case, I believe it took a few weeks, and we got ready for the FET, which is the frozen embryo transfer part. And that, in a nutshell, consists of like estrogen patches and progesterone, either suppositories, which are like 2 or 3 times a day, or 1 intramuscular progesterone shot for about 3 to 4 weeks. And so what we did was, in total, 4 IVFs, 7 transfers. We have 2 babies and 4 embryos that are HHT free, so to speak, left. And just to give an idea of the breakdown, the first time that we underwent IVF, we had 18 oocytes or eggs, and then that were retrieved. Miraculously, 18 fertilized, 17 made it to day 3, 15 to day 5, 9 had my gene copy, so they had HHT, and 6 had Simon, my husband's gene copy, and were HHT free. So that's sort of a high level with some detail about the overall process. And the biggest question, or the most frequent question I get, is about cost. And this is in the US, the only experience I have. I know other countries will cover a significant portion, if not the whole thing. But I find here many insurance companies don't cover it. So like Katie had said, the IVF piece is about $12,000. ICSI adds a little bit to that. PGT is $6,000 the first time. It's about $3,000 to build these probes, and then $3,000 to test the embryos. And then we added that PGS piece, so the chromosomal check piece. And I'm not sure if this is accurate, but I remember we were told that if you add this to the testing, it ups your success rate of the embryo taking up to 70%. So we did that. There's an additional fee when you do PGD, at least that we found. There's about $1,000 biopsy fee, and that's, I think the lab has to send somebody very specific to get the sample and handle it and ship it. Meds can cost anywhere, I found, from $3 to $6. And then the FET usually is covered with the IVF that first time, because they usually do a fresh transfer, but in this case where there's PGD, you have to wait for a frozen transfer. And then you have storage costs of the embryos, and ours were $3,000 a year per cane, and I have zero idea how many are in a cane. I know that we have a couple, and I found that you can, some areas you can cut costs on. Some people will bank the embryos, so they'll do multiple cycles and freeze all, and then the samples are frozen and they'll test them all at once. That's a significant savings. And in some cases, insurance will pick up some of the blood work, labs, and med fees. And then for the frozen embryo transfer on its own, it runs about $2,000 to $3,000. We budgeted about $20,000 to $25,000 for the first cycle. My husband works for a large academic medical center, which allowed us some coverage, which was incredibly helpful. It's expensive, but worth it. I would save and overextend myself again without a moment of hesitation. I always personally think about the peace of mind, the long-term worry and pain that's saved, the lifetime cost and resources and time saved by kids not having HHT throughout their entire lifetime. And that's, countless copays and MRIs and scans, possible transfusions, ER visits, urgent care, missed school, the list goes on and on. And the most important part to me is the quality of lives, and not just their lives, but literally the kids, you as the person who takes it on, partner, cousins, friends, grandparents, uncles, aunts, teachers, coaches, their future spouses, future generations. It goes on and on. And then we had a long road, but we're looking to transfer our third next. Next month we'll do another transfer, and there's always hope at the end of the road. It's a long one, but it gave us 2, maybe more incredible HHT-free kids. So my takeaways, basically, it's always advocate for yourself and your family. So my decision might not be right for you or you and your partner, but just be informed of all the options, and no one can tell you what you believe is right for you is wrong. And throughout this process, you have to remember that when there's downs, there'll be highs, and when there's highs, you have to brace for the falls. It's incredibly taxing when you go through it. But then on the flip side, and I tell everybody this, I know so many people who have done IVF. It's not just for genetic conditions, but across the board, when you prep and you're going through it, it can be and it will be incredibly tough. There are periods where people couldn't tell me anything. I thought it was all doom and gloom, and it took me forever to go back and find all this information because I completely forgot about it once I had, my first child. I promise, once everything comes and you're where you want to be, you forget about all the pain of the process. And then lastly, I'm available. It's usually after bedtime, but I am more than happy. I've talked to people through the foundation before. I'm more than happy to Skype or call, whine literally and figuratively over Skype, share, offer support, connect you, anything. So thank you so much for listening to me tonight. And again, I'm an open book. So I think Nicole is going to take over and bridge us over to questions.
Well, thank you, Katie and Despina, for a very thorough overview of IVF and pre-implantation genetic testing for HHT. And we especially appreciate you, Despina, for just having such an honest and open conversation. I know some of that was really difficult for you to relive. So we do appreciate you sharing that with others who I'm sure have experienced some of the same things. So we do have some questions. And the first one, I think, really has been answered by both of you, but just, again, that insurance coverage question, and wondering, does it make a difference if it's for genetic reasons? And I don't know, Katie, do you have any insight for that?
I think it would just depend on individual insurance policies, and if they just, what the policy says. Like, if it's, you have to show that you've had infertility before you can pursue IVF, or if they don't have those requirements. And honestly, I don't know. I do know, like, at my institution, I work at a large academic hospital, that they cover kind of like a flat fee, but I haven't looked any farther into like the reasons for like what the criteria that you'd have to satisfy before they would cover that are. But Despina might be able to talk about like their experience.
So we didn't fit into like the unexplained infertility category beforehand. I'm trying to remember. I think that we had to have a conversation with somebody in HR, but it was covered. I'm not sure. It's on a case-by-case basis. I'm pretty sure. I've seen, and I mean, I would be hard-pressed to say that if you made a case for the insurance company that if they do offer benefits, that they would exclude you like that. But I've seen insurance companies do crazier things. So I don't know. Katie's right. That's probably totally case-by-case basis.
Okay. So Katie, what are the odds of, if someone goes through genetic testing, of finding the mutation, of identifying the mutation to the point where they could go through this process?
So most people who have HHT and they know that they have it for sure, they've seen someone who's diagnosed them based on their symptoms. Most people, so 85 to 90% of people, would have positive genetic testing that could then allow them to pursue IVF and PGT.
Okay. Despina, for you, they're asking, how many years in advance did you start the process before you had your first child?
Let's see. My daughter was born in the very end of 2015, and we started probably end of 2013. I'd say like a year. We did have some setbacks. I personally wanted to do, we weren't having successful transfers, and so I wanted to stop and do IVF again and bank the embryos. So it took a little longer than expected, but I mean, I think a typical case is, you go in, and if you're ready, these fertility clinics really are good at, getting the process started. They basically sync everything to the woman's cycle, and provided everything is fine lab-wise, you proceed. There's a little bit of the lag time with the probes. I think they have to build, I know they have to build the probes first. For us, that took months because we were like the very first HHT case, I think, and now I hear it's like weeks. And I would say typical case, all in, it shouldn't be over a year. But I say that, and I think that you could probably have an initial conversation with a fertility clinic just to see, what the process is going to look like, and then decide when you feel confident to start, because there are a lot of hiccups along the way. Nothing goes quite textbook. I wish that it would, but I would just allow yourself an initial appointment and then go from there.
Okay, great. Thank you for that. Katie, someone is asking that if the mutation is not in that 85 to 90%, like, what would their next steps be?
Well, like I mentioned, I think making sure you've seen like a genetics provider, a geneticist or genetic counselor in an HHT center of excellence to make sure, is it HHT that you have? Have you had genetic testing for those other genes that aren't always tested for the first time around? So the EPHB4, the RASL1 gene, or sometimes the GDF2 gene you might not have been tested for. So thinking about doing that testing. And then there are some genetic changes that we know aren't routinely tested for on the genetic testing that you can just kind of typically order today. But that is probably changing. And the reason for that is, for a long time we've known there are different parts of genes, and we've known for a long time that genetic changes in what's called exons we know can cause genetic conditions, but there are also introns, and we don't routinely test for those because really scientists up until this point didn't know how to interpret those. And so now we're understanding more about introns, and genetic testing for introns is becoming more common. And in HHT, we do know that there are some genetic changes in the introns. And so when that testing becomes available, it'd be potentially easier to find the genetic change in a family where we haven't been able to find it before. But there's no guarantee that that would kind of be the answer. And then certainly if you have like an intronic mutation, what that would mean for PGT and the PGT lab to be able to detect that is a conversation you have to have with them. Because like Despina was talking about, they were the first case that PGT lab had done for HHT, and so it took them longer. It could be the same case for if you have a different type of genetic change.
Okay. So a question about IVF just in general. Do you know what the percentages are that someone would have a multiple birth through IVF?
I don't specifically. I think, it used to be that fertility centers transferred many embryos, and now more centers have policies around how many they would transfer. But you probably have to ask each center kind of what their policy is and what's the chance. Despina, I don't know if you remember kind of what you were told, at least for your case.
Yeah, so when we weren't having success with the transfers there initially, I said, well, why don't we put in more than one embryo? And they were like, no, because you have this history. So I think if you're the one with HHT, they proceed very, very cautiously. And I think across the board now, they are very limited within their code of ethics, what they're willing to do. I think if you're older or you freeze your eggs when you're older, like it's an older egg technically, they will take that into consideration. Or if you have multiple, failed attempts, they take that into consideration. But I think off the bat, they do what they call like I forget, it's like a SFET or S embryo something, where it basically means single embryo transfer. At least that's what they had told me. And so I think that then your rates are, whatever it would be for a spontaneous identical twin sort of situation, multiple situations. I think fraternal twins is out of the question because, you're not ovulating when you do it. And so I think, they will probably only transfer one embryo at a time.
Okay. So a question about, does the couple choose the fertility clinic, or does each hospital tend to work with a specific fertility clinic? Because there's only, maybe like 30 in the country?
I think you mean the lab?
The labs that are going to house, like, what is the differences there between working with a genetic counselor, working with a fertility clinic, and actually the storing and all of that of the embryos?
So what I would say is, like, if you're at an HHT center, they may or may not have a fertility specialist associated with their hospital. So like in Cincinnati, I know of a fertility center that is in Cincinnati, and so I can refer local patients there, but the fertility center isn't affiliated with our hospital. So I'm trying to get at if that's the question. And then for the fertility center, each fertility center is going to have a PGT lab that they contract with and that they send all of their embryos for testing to. And so I would say that you're typically choosing the fertility specialist and the fertility center, and then using whatever PGT lab they use.
Right. That's exactly right. I think if your insurance will cover a piece of it, they may or may not dictate what initial fertility center you go to. For us, my husband worked for a health system that had one, and a good one, so we used it, and they also were super willing to communicate with the Center of Excellence here. They're literally, a few miles from each other. And then they, because it's a lot of legal contracting in the background, have one testing lab that they use. And to my knowledge, you don't get a say in anything but the one that they've contracted with.
Okay. I think that's very helpful. How long can you freeze embryos?
Forever. They can stay frozen forever. I'm not sure what the oldest one that was transferred is, like, historically, but I was told that they you can wait a month, you can wait a year, you can wait 10. I do know, and this is sort of off topic, that the younger the woman's egg is, typically the more success you would have in a transfer, but they're frozen indefinitely.
Okay. And so you talked about retrieving eggs. How many eggs, is there a limit to how many eggs can be retrieved for IVF purposes?
Is there a limit? I think the limitation comes into how many do you have available, because you're taking the hormones to kind of stimulate your ovaries. And so you can only take the ones that are, mature enough that during that cycle. So it's not that you take these hormones and all of the eggs that are in your ovaries are there and you can harvest them. You just have, whatever you have is there, and they, I believe, tend to take as many as they can when they're retrieving them.
Yeah, and it's a very fine dance between the medication and the monitoring. So towards the end of an IVF cycle, you will go in for daily monitoring, and the blood work measures your hormone ranges, which tells them, about how many mature follicles you have, and they don't want to run the risk of, one rare side effect is overstimulation of the ovaries, where they just become really big and they overmature them. There is a limit to what your body can do, and that they can't tell you if it'll be 2 or 20. It's all on a very individual, like Katie said, it's between what your body will do and what your doctor, based on their experience, thinks is right.
Okay. So this is an interesting question. It says, are there any risks to the embryos when PGD is done? For example, congenital deformities or missing genes or something other than just, trying to find the embryos that are HHT free?
Not that I know of. There is some risk that just the act of doing PGT itself might make it less likely that you become pregnant. But there are no risks that I know of, to the embryos as far as deformities or birth defects, that sort of thing, that are outside kind of the normal chances. So about 3 to 5% of pregnancies have a chance of having some type of birth defect.
Okay. And why would you say that PGD reduces your risks or reduces your chances of becoming pregnant?
I don't know that we know that.
Okay.
I don't. So I don't specialize in PGT because I don't work at like a PGT lab or an infertility lab. And so maybe someone who does would know, but I don't know that we know the answers to that.
Okay. And then I would say our last question this evening, which probably both of you could give some insight, would just be, where do you find the most support or information about this? Because it's obviously very complicated. There's a lot of different parts. There's different specialists that you're working with, different clinics. So, you know, what kind of advice would you have for someone just as far as finding good support and information if they're going to consider pursuing this?
I think online can be your best and your worst friend. I would start there in looking at, a fertility clinic to go to, and then I would make appointments to meet with the team of fertility doctors, and they probably have the best resources in terms of where they've sent people. They may know if there's somebody with HHT that's done this or tried this. I'm always here for support. I know there's other people online who will post that they've done this within the HHT community. I've found that they're willing to at least post, so I'm sure they're willing to share. I would stay off forums. I throughout the process tried to like superimpose myself into what information I was trying to find, especially like throughout the process, and I think that that's not beneficial. Katie's here with us tonight and is super qualified to, get you in touch with someone in your area. So yeah, there are lots of resources.
Do you think it's important, like Despina said, to find like a fertility center that you're comfortable with? Because you're going to be going through a lot with them and you're going to be meeting with them. Despina was talking about, daily monitoring and that sort of thing. And so I think they're the people who are going to know the most people who have gone through PGT for whatever reason. And so they might be able to hook you up with people who can be supportive. Your HHT Centers of Excellence might have some patients who they know of who've gone through the process who are willing to talk with you. And there is, for different fertility centers, they have a lot of information online about like what their costs are and what the process is. And so if you know of a fertility center near you or that your insurance covers, it might be the first step to look up the fertility center online and see like what information do they have out there? What do they recommend? Is there anything that you need to call them about to ask them before you even consider going in to see them? And then thinking about, depending on when you're wanting to consider getting pregnant, talking with them and kind of going through all those steps to figure out like what would the timeline be for you.
Okay, fantastic. Well, we have reached the end of our time this evening, and we're extraordinarily appreciative. This is a new kind of topic, but also one that is very much spoken about in the HHT community. And as Despina mentioned, she, is willing to put herself out there and give support, as well as all of the HHT centers. So from all of us here at Cure HHT, we want to thank you for attending tonight's webinar. Our shared goal is to advance one common hope, to give those affected by HHT a chance for a normal life. And this webinar series is just one of many ways we accomplish our mission. We're grateful for the donors of Cure HHT for making this and all webinars possible. So please consider donating to Cure HHT to ensure we can continue to offer high quality education for you and your family. And after the webinar, you will receive a short survey. So please take a few minutes to complete it so we can better serve you in the future. And again, I just want to thank Katie and Despina, they both have young children, for volunteering their time this evening and for leading this webinar, which has been recorded and will be posted on our website at www.curehht.org in our resource library. We truly appreciate your participation, and we hope you enjoy the rest of your evening. Good night.